So it was rather a very interesting and intriguing panel discussion. So today, my task is to go through a slightly different topic, which is artificial intelligence and how we can actually apply it in our healthcare situations. So here, what I am discussing today is basically this is our artificial intelligence lab, which we are using in our hospital. And this will be the code behind the scenes, behind the results which I will be showing you. And why is this important in this particular scenario, specifically in cross trial? So what we have seen in earlier talks also, pathological complete response is something which everybody is looking for, and various trials have shown that various regimen has been applied, and they all are used in definitive surgery regimen as a neoadjuvant regimen, and they all have shown that with time, if we look at the time trends, so what we can see is that pathological complete response has gone up, and the post-op mortality has gone almost negligible within modern techniques which we are using. And if we look at the subgroup of patients who are achieving pathological complete response versus with the residual disease, this is our own data which is under peer review, and we did found that patients who achieve pathological complete response, they do very well, and there's a remarkable difference between the survival in terms of complete response, as well as in terms of overall survival, as well as in terms of relapse-free survival. But we have reached a plateau. Actually, whatever we do, because there is a normal tissue complication probability which holds us back, because whatever we do, whatever dose escalation approaches, whether chemointensification or immunointensification, whatever we do, we are not able to achieve pathological complete response beyond 50 to 60%. We can actually criticize that intergroup trial 0, 1, 2, 3 because they use 2D techniques, but with Concord, which used three-dimensional technique, and in fact, Attendeco trial, they used an IMRT approach. But still, we are actually at a threshold of 50%. And why I am focusing on complete pathological response is, if we can predict complete pathological response prior to surgery, then there are different approaches which can be applied, and already there are ongoing trials which are being there. In fact, this is a very provocative statement of escalating radiation or a chemo de-escalation in patients where we feel that these are going to have a pathological complete response. But avoiding surgery is already being looked upon, and maintenance immuno is already being looked upon. But what we need to do for this particular approach is we have to have a better imaging techniques, and also along with accompanied by a bite-on-bite biopsy, not a normal biopsy, random bite-on-bite biopsies. We prove it that it is like there is no pathology, there is no residual disease, and then follow them very rigorously. There's a very rigorous follow-up protocol which is being applied to these patients. So in nutshell, these are the tests, these are the investigations which can be done prior to surgery, post-neoadjuvant chemotherapy. But if we look at the sensitivity and specificity of all these approaches, they are not satisfactory, not to the mark where we can actually avoid surgery on the basis of these investigations. In fact, our own data, RGCI, for primary tumor as well as nodal, there also with regard to the PET scan, it was in the range of 50 to 60% for sensitivity and specificity. There is a very interesting approach in Scope 2 and ESO Shanghai 12, where they are using an interim PET during the chemoradiation, post-chemoradiation at 4 to 6 weeks, and between chemoradiation. And if there is some residual disease, probably they are changing the course of treatment. And again, these are interesting approaches. But if we can complement these investigations with an AI technique where we can actually do some sort of prediction whether these patients will achieve pathological complete response or not, then probably combining the sensitivity and specificity of all these investigations along with complements of AI and deep learning approaches, probably it will further help to have a better protocols, and probably we can have something which will have an immense role in these design of these particular trials, as well as in prediction of pathological complete response. So this is the whole scenario of cross protocol, and we have actually staging workup where we do imaging, and then there is a treatment, one which is chemoradiation, followed by a gap of 4 to 6 weeks, and then there is definitive surgery, followed by histopathology report, which we get, and then there's the outcome. So if we want to predict a pathological complete response using AI, then these are the things which I have already discussed. And how we can do this is basically by using these images. First is the pre-treatment images, where we can actually get some information from these pre-treatment images by using artificial intelligence approach, or a post-treatment image, or a delta of these two images, or using a clinical feature. So combining all these information and subjecting all these information into an AI model, and then probably it can predict some sort of the prediction of pathological complete response. So giving you a very brief overview, because I can't go into a detail what exactly I am talking about, how we will use this particular approach, or how we are using this approach. So overall, this whole field is known as a data science, and which is a complex interplay of many things, which includes artificial intelligence, machine learning, and deep learning. As we go high in this chart, the things become more complex. And in this particular scenario, we will be using radiomics, as well as we will be using some deep learning approaches and a machine learning. And what's the basic difference between these? I will come to my next slides. So before going forward, we must understand what is not AI. So anything which is an explicit programming, where actually like any software which we are using are not artificial intelligence. What artificial, like explicit programming is like, we have a data, we have historical data, then we do some sort of statistics and apply some rule to that particular data, and then we get answers. This is in programming, this is an explicit programming. But when we are talking about AI or a machine learning, then we give a historical data, we give answer to that particular algorithm, and it learns from that particular answers, and it generates its own rule. Once those rules are learned, then probably we apply these rules to our future data or a new data, and then we try to predict. So this is what the actual artificial intelligence is. And we have been traditionally taught a traditional way of doing a research is a hypothesis-driven, where we formulate a hypothesis, then there's a data collection, we analyze and interpret, and then we get some sort of a new candidate biomarker, and then we do a technical and clinical validation. But it has its own limitation. For example, when we do radiomics, we extract some features from the images. And these features are in the range of 10,000 or 15,000 features we extract. So here we cannot formulate a hypothesis prior. What the traditional approach is a data-driven approach, where you collect data first. You have a multitude of features you extract from these images, and then you do a technical validation, whether what features are important, what features are not important, and then you go through a discovery phase, and then you discover some sort of particular biomarker, and then you do a hypothesis, and then you generate a particular model. So how these clinical models, how these artificial intelligence algorithms, they learn. So it is being derived from how the human learn. So human brain is very complex. So just to simplify it, our neurons actually, they receive some sort of information, they pass through multiple neurons, and then some particular information is retained, which is like correlated with what the scenario is, what we are seeing, or what we are trying to do. Similarly, these artificial network, they also do the same thing. We have been using artificial network in a great way. There are a multitude of layers, which you can see here. These layers, if you see, these are the nodes, these are the neurons, which we call in artificial intelligence, and there are multiple layers of these neurons. They are nothing, they are just a mathematical formulations, and the information, the features which we extract from images are passed through these layers. So once these features are passed through these layers, we get some sort of an answer. Like here it is an example of a digital recognition. If you want to recognize a particular digit, the information passes through these layers, and then it tries to predict. If it is wrong, then whole thing goes back, and whatever the connections between these nodes are there, these are called weights, and if the answer is correct, that weights are being retained, and once we get a new information, then using those weights, it tries to predict the further future predictions. So this is in a very higher level overview of these things. So when we are utilizing these approaches, so there are two basic approaches which we are using. One is a radiomics or a machine learning approach, where we have these images, And these images are nothing. These are numbers. These are pixels or voxels. Ultimately, these are all numbers. So tumor here is in orange, the number which are represented by orange. And then we do a sort of mathematical calculations and derive some features from these images. So this is basically the extraction of a mathematically or statistically derived features from the medical images, which represent the distribution of pixels and voxels and their interrelationship without any a priori hypothesis, which is very important. And once we get these features, then we actually go into a feature selection, because all features are not important. Then we go into a discovery phase. We apply different form of statistical things, and then we do a validation, external or internal validation. But in a deep learning approach, this feature extraction is automated. So we don't have to manually extract these features using some software. Everything is inbuilt. We have a neural network, and we have a convolutional layer where we just subject the image to this model, and it extracts the feature, it selects the feature, it discovers the features, and it tries to predict what will be the answer. What in this case, we are trying to answer whether it is a malignant disease or a benign disease. And what is the basic difference here between machine learning versus deep learning is, again, just to emphasize that this is a tumor. In machine learning, we extract features manually, and then we subject it to artificial neural network. While in deep learning, this is the model, this is the convolutional layer which is doing everything. We don't have to do anything. We just subject the image to it, and it extracts feature, and it subjects to artificial neural network, and then we do a prediction. So this is what we have been doing for last couple of years, for last 3-4 years. And we have been doing these approaches, using these approaches for lung, esophagus, thymoma, breast. So today, I'll just briefly discuss the results of our studies. This was the initial preliminary study which we did for carcinoma esophagus patients. In this particular scenario, what we did was we extracted radiomics feature. There were approximately 12,000 features. And then these features went into a feature selection mode, where ultimately we got 254 features. We applied some statistical analysis or machine learning approaches, where we zeroed into 15 and ultimately into 7 features. And then these features were subjected to a neural network, where we finally discover the features, where we finally were able to generate a model with an AUC of 0.87. So this is anything which is more than 0.8 is quite good. But the problem with radiomics approach is, because there is a manual interference, we have to manually extract using some software. And this was a very interesting paper by Welch et al. So as earlier I have explained you that if I split that image into 4 parts and randomly present you, so that's very difficult to interpret what exactly we are dealing with. And this is the image. The orange is the tumor here. This is the voxel representation of that particular tumor in a CT scan. And if I randomly rotate those voxels, everything changes in that particular tumor. But what they found was, with this rotated voxels, or randomly rotated voxels, they extracted the feature. That model was still were predicting the right way. So this was quite surprising. So everything changed inside that particular area. So what they hypothesized was, basically it was biased toward the shape and the size of the tumor, rather than those all features which were extracted were ultimately representing the shape and size. So there is some sort of a bias, selection bias of these particular features. So then there's come the role of deep learning, because we are not dependent on any software to extract those features. And this was a very remarkable paper by Hosner et al. It was basically for lung cancer patients, where they subjected the CT scan, the cropped CT scan of the patients, and they tried to predict the survival. And they found that there was a drastic difference between the patients where they predicted that survival will be good, or where they predicted survival will be bad. And the very interesting point here was, when they back projected the weights of these artificial neural layer into the CT scan, it was actually focusing on the areas which were representing tumor, or a peritumoral area. So it was nothing like a black box. It was actually, we have not told that to the model that this is a tumor or this is normal tissue. It was ultimately, by itself, it was going into those particular areas which were representing tumors, and it was very intriguing. So we used this particular approach, and this is our project, which is an ongoing project. It is in quantitative imaging, artificial intelligence, and radiomics combined with clinical data. And this has been already registered with clinicaltrials.gov. The approach is same as I have told you earlier. Usually pathological CR, they fare better, and we are interested in predicting this pathological complete response. So we do use a deep learning approach based model and radiomics based model. We're trying to compare what's the difference between these two approaches. And we will be doing an external validation. We have received data from our Australian counterpart, Dr. Andrew Miller, and this will be an external validation. We will be doing an internal validation, applying this model to a new data which we are generating from our clinic, as well as we will do an external validation from our Australian counterpart. So this is the initial preliminary results of our study, which were presented last year in ESTRO. This is an CT scan, which you can see here, and this is a tumor. So along this tumor, we have been cropped images. 64 by 64 by 64 image was cropped along this particular tumor, and then this information was represented to the model with no segmentation here, this whole image. We have not told the model that this is an esophagus, or this is a bone, or this is airway. We just have, just 2 slides more. We just presented this image to the model, and we actually found a very good result. And again, the same thing, we tried to back project the weights of these particular layers, the last layer, into the tumor, and again it was focusing on the esophageal, periesophageal area and the mucosal area, and our actually accuracy rates were 75% or 75% for internal validation. It was 80% the accuracy rate of this particular model. So lastly, I would like to say that this is not going to replace us. Basically, it is an assistive approach which will assist us in future in a great way, and this is what I feel. And I would like to thank my whole team behind the team, which because of their hard work, we were able to achieve this all. Thank you. Thank you very much. And lastly,